So this session called my case of the year, but it's not of this year. It's actually from 4 years ago when I was second year after fellowship. I never ever presented this case anywhere, so I thought maybe I should present it this time. So the motto of this case, if I could go back in the past, that's what it's about. So it's 50 years old man, a young man, essentially healthy, who comes with anterior STEMI that hibernated there for a few days, eventually presented, and what you see here is left main occlusion. But the good part about this case is that right coronary artery keeps him alive. One of these cases I think was shown earlier today. His right coronary artery is a donor artery, but it has also a disease. A balloon pump was inserted. He went to ICU bed. LVEF was 10%, and he was basically as a poor prognosis case. 3 weeks later, the patient is still alive. He's on hemodialysis, had a stroke, has debridements going for bilateral compartment syndrome. I think he had rhabdomyolysis and maybe some balloon complication as well. Massive inotropes. EF is now 20% on contrast perfusion echo is off-label indication. We do it all the time, especially when MRI is not possible. And this is 3 weeks after his presentation. Eventually, we in complex PCI program became aware of this case, because that's another important key in this case is that communications is so important in heart team. So this time, 3 weeks later, you can see that his actually collaterals still there, but his left system is also opening up, recanalized to some extent. Remember, 3 weeks ago, his left main was completely occluded, and myocardium is still viable, probably hibernating a lot. So this is a case, after further discussion and planning, we decided to go with Impel ACP. It was only second year available in Australia, this device. And then trying to secure both LAD and circumflex. This is transradial EBU 3.5, 7 French. And once antegrade system more or less secure, and then I decided to treat right coronary artery. I was based. Nowadays I don't use Philips much. It's mainly Boston with 60 megahertz, but this is what I had then. And whenever you occlude the flow in the right, patient becomes completely dependent on the impeller, and that kept us actually in a safe position along with the patient. So 2 stents were deployed based on IVUS. There is not much calcium there, so we didn't have to deal with special treatment of the calcium. So now we started left system intervention. What would be your approach here? And then I put small balloons, both to the proximal circumflex after LAD treatment, and that was for IVUS to cross. And IVUS allowed me to precisely know what kind of balloons and stents to use. So with these cases, you try to minimize contrast injections. It will obviously will be negative for the LV function, but also will cause dissections. Having intravascular ultrasound allows you to minimize the contrast and to avoid pressurizing the vessel antegradely. So then LAD stent goes in, and planning left main bifurcation. In this case, I decided to do decay crash, so I left some space there. Then the idea is to open the circumflex, brought Corsair, changed the workhorse wire to Pilot 200, and easy crossing into the true lumen with retrograde injections. Then changed back to workhorse wire, and did some ballooning. And of course, using IVUS again. Then further balloon dilatation and deploying a stent with small protrusion. Obviously nowadays you can do nano crash, etc. But a few millimeter protrusion, crash the stent. And on stent life that we use in Siemens, you can see actually the stent is crushed. And now this is a rewiring step, opening the ostium of the circumflex, finishing the post-dilatation of that 2.5 stent with 3.0 NC, along with the ostium, then first kiss. So you have to follow steps here precisely, because that's the only chance for the patient. And then preparing for the final stent on the left system. That's what I thought initially. 3.5 for 0 pot, then rewiring circumflex. And then ballooning left main struts to circumflex. Then a second kiss, and again pot. And then decided to put one more short stent into the right. The disease obviously ended in the disease, the stent, first stent landed in disease segment. Now I'm quite happy with right coronary artery. And then decided to put one more stent in the LIZ. Again, short stent there. Everything was IVUS guided. Nowadays I would probably use DEB for that particular purpose, for the mid-LIZ. Then all control checks. It's a final result of the left system, kind of before and after. This is 3 weeks after original presentation. So Impel ICP in ICU was weaned off to inotropes. His LVF was 20%, has not improved much post-PCI initially. 2 weeks later, he's still in ICU, has further surgeries for his both legs debridements on inotrope and going to in profound sepsis. And the day before he died, his LVF was more than 30%. So kind of that's the reason I didn't show this case anywhere, but I thought there are some educational points from this case. One of the most important is to have heart team approach when patients like this come in, surgeons, interventionalists, heart failure. Everyone is notified, 50 years old. Obviously, there was mainly heart failure in ICU calling the shots along with transplant team. If we knew about him early, probably on day one, things could be planned a bit differently.
Yeah.
Thank you.
Great case, Doctor. Yeah, that's indeed a great case. Why did you elect to do the right first and not the left? Because the right was anyway flowing. There are some lesions, so open up the left and then do the right?
A good question. Most of the time, obviously, I wouldn't do that, but I thought this is relatively a simple artery to intervene. There is not much calcium. If I required, for example, rotablation, then I wouldn't do that. But I thought I will just put a stent stay quickly. I have impeller support, and then I'll just spend all my time on the left system. But you're absolutely right. If there was more complex lesion requiring rota, ideally just deal with the left, and right can be addressed at a later stage.
Was the right a significant lesion?
Yes, it was a significant lesion on IVUS.
On IVUS.
Thank you, Dr. Rustem. It just shows what we did discuss in the morning, that cardiogenic shock, despite everything that we have, still the mortality is around 52%, even with the MCS. Thank you very much.
Ronnie sir, just a question. So what's your thought on this particular case? If he had, if he were to be taken up for a primary angioplasty 3 weeks prior, would he have survived with this sort of intervention? I felt that he was much safer, it was much safer for us to do because there is no clots over there 3 weeks down the line. But if you had done it much earlier, probably again we would have probably lost him because of slow flow inside that vessel. What is your thoughts on this?
See, I think, see, if you look at it from the initial shock trial, now we are 30 years down the line. Our mortality is 52%. Right now we have the shock with this one, ECMO. Even then the mortality is 52%. The only thing I believe that can change the mortality of this is intervening early. Period. He may still die, but I think intervening early is the answer we have got after all these shock trials.
Ronnie, but then the point of contention is, agreed mortality is high, but 48% survive. In the absence of an intervention, you don't expect them to survive.
No, I am saying reduction of mortality from 50% down.
Yeah.
It has not
It's-
happened in the last 40 years.
Agreed.
Despite IABP, MCS, ECMO, I mean, name it.
Right.
OCT, stents, third generation. The only thing in my view that can change this mortality is if we intervene early, get your window period down.
So it's just not the cardiac issues here, as in this case. It was all the non-cardiac issues which ultimately
He battled
resulted
a lot
in
of
this.
other
Yeah.
issues also.
Swati Mahesh wants to make a point.
Could we have put the impeller on day one?
Pardon?
The impeller on day one, the things would have been hastened and the recovery would have been faster.
No, his question was not impeller. His question
My
was, will
question
you
is
open
imp-
it?
My question is impeller.
Oh, your comment. What do you think, Dr. Rustem? I think we should ask.
Yes, I think the problem was in this case that we of this PCI program, we didn't know about this case. So the case was run by heart failure team, by transplant team, and it still remains, it's a bit political. What I'm pushing for, when cases like this come in, we get notified and make decision together. I think 50 years old man with good reserve should have, had different outcome. He died of sepsis despite the best things we could do.
What about assist device in this situation? Ventricular
Assist devices, whether
Yeah, absolutely, absolutely. But what we usually do in this case is we put either ECMO or we put impeller, and then it can be really something more in a week time. It could be LVAD with surgeon. It could be LVAD with surgeons. It could be a transplant, etc. But the first day or two were critical, and I don't think it was managed appropriately.